Hello and welcome to Perez Prosthetics Continuing Education Webinar for Physical and Occupational Therapists in Ohio and Michigan. We are thrilled to have you here and appreciate your commitment to furthering your skills and working with the amputee population. Now, before we get started, let's go over the steps to receive your CEU certificate. First, please make sure to watch this video in its entirety. Once you've completed it, click the link in the description below to access the online quiz. After taking the quiz, send an email to the address provided in the description to let us know that you've completed the course. We'll then send you your certificate of completion along with a quick survey for feedback. If you have any questions about the material or the process described in any specific webinar, never hesitate to reach out to us at the same email address, or you can visit us at perryprosthetics.com. Thank you for joining us. We're excited to share this valuable information with you.
All right. Well, it is the stroke of noon, and I want to thank everyone so much for coming and attending this, especially on this beautiful, it's fall now day, because summer is just done. My wife school's back in. My wife bought her first fall decoration yesterday. It's official. So not only did you take up time of your day, you took up your lunch and you took up a beautiful weather day. So we really appreciate all of your commitment, not only to education, but for joining us personally. If you are not familiar with Perez Prosthetics, we are a company who was founded in 2000, which means we are celebrating our 25th anniversary as a company. Geographically, we are located, our hub here in Perrysburg, Ohio, just on the outskirts of Toledo. We also have an office in Findlay, Ohio, and then one up in Ann Arbor, Michigan as well. We are dedicated to a program called CARE, which is what you're experiencing right now. It's our education platform, which launched this online version of it just this past year. And we're very proud of that. It is connecting medical professionals to ultimately produce better outcomes. And that is just one of the biggest pillars that we have for our education program, which coincides with our 4 pillars of our objectives, which is patient safety, their satisfaction, our efficiencies, and then ultimately outcomes. And there is not a microprocessor knee, not a super fancy myoelectric hand in the world that can give a patient a successful outcome without the paperwork to support it. And so that is what we're going to learn today. So I'm going to make my introductions, and then I get to just sit back and relax. To my right is Michael Perez. He is our clinical manager and a certified prosthetist and orthotist for all of our branches. And then Dr. Stacey Hoffman, I'm going to let you introduce yourself, kind of talk about your background, what your day-to-day looks like for the amputee population. You can talk a little bit about clinic if you want to as well. And
Sure.
Once you guys are good to go, we will go right into the presentation.
All right. Thank you so much. I appreciate the invitation. My name is Stacey Hoffman. I am a board certified physiatrist. I've been working in physical medicine and rehabilitation for 15 years now. And I am employed full-time with Mercy here in Toledo, Ohio. And there are 4 of us full-time physiatrists in the practice who are seeing patients in the hospital setting, in the acute rehab setting, and then also in the clinic setting. And so our specialty actually started in the VA system with returning vets who had limb loss. And so it's a big area of passion for us. And we love to work with people as early as possible to help them know that there is life after limb loss. And so navigating some of the pitfalls and challenges that healthcare in America in 2025 presents all of us is something that we have been working toward for a very long time. And we think we've got a very nice workflow put together. Our group does an interdisciplinary amputee clinic, as many PM&R physicians will do, which includes the prosthetist. And sometimes, occasionally, we need therapy involvement in the clinic as well. So what's nice about the interdisciplinary clinics is that they give the patient sort of a one-stop shop. And then it's just great continuity of care when everyone is seeing the person at once and understanding the challenges and the barriers and the goals that the person has to get back to living their life. And then making sure that we just say those magic words in the record to make it the least painful process possible.
Wonderful. All right, Michael, I'm going to let you introduce yourself and explain to everybody why you don't have as full of a beard as you do in that picture right
It's
there.
gone. It's not cold enough yet. Well, it is fall. Football hasn't started.
Come back in
Hunting
a
hasn't
month,
started.
and
Yeah,
we'll check in with Michael.
We'll get on that. I just got out of vacation from Florida, so less hairy. So as Darren was saying, I'm the clinical manager at Perry Prosthetics. I am a licensed and certified prosthetist orthotist. I'm primarily in the Perrysburg location most days out of the week. I'll go where needed though. I do attend some of the clinics that we have going on, whether that's wound care clinics or PM&R clinics. And I really just kind of hope overall direct the flow of patient care that we have, helping oversee fabrication that we do in our own lab, as well as making sure that we have the right workflows for the prosthetists and the team that we have involved, and making sure that we're achieving the high outcomes that we're proud to say that we achieve with everybody. So yeah, I'm looking forward to talking about paperwork today, as weird as that sounds, because it's an area that I've gotten closer to over the last few years here and working with the team, which is really what this is all about. I've learned a lot, and I feel like there's a lot to share, and there's a lot about this process that people don't know. So that's what makes it exciting to me. So I'm looking forward to it.
Perfect. All right. I guess I have one job. I am going to advance the slides. So, all right, Michael, talk to us about the gold standard perception.
So this all started kind of back in 2010, the requirements for all this paperwork that everybody perceives it to be. It's a little overwhelming if you're not familiar with the process or what's required by the insurance, and it's really Medicare standards that we go by. We don't require any more than what they're looking for. We try to keep it to the bare minimum because it already feels like a lot to everybody. But that's really our gold standard. We know that to provide the care that we're after for our patients and to get them what they deserve and what's going to best get them back into life, this is one of those requirements. So we've tried to create standards and methods and processes that lead to efficiency through this process, such as the clinic, which we'll talk to, and Dr. Hoffman's already kind of commented on and hinted at. But we follow Medicare standards, which again is kind of the bare minimum, despite it feeling like it's so much, and really involved. And we'll talk about kind of the things that we've adapted along the way to try to make it a little bit easier for everybody involved, and to really make sure that no one physician or individual signing off on a script or for providing documentation to us has to memorize everything that's covered today. There's things in place that we do to try to help and eliminate the burden on them that is felt across the board.
Perfect. All right. Now we get to kind of dive into this interdisciplinary approach to this presentation, where we talk about the timeline. Everything's color coded so beautifully to talk about like what is in Michael's world and what is in Dr. Hoffman's world. So Mike, I'm going to have you kind of just give an overview of what we see, and then we'll let you guys kind of go back and forth about each individual block.
For sure. So the things that are in red are the things that we rely on Dr. Hoffman and the physicians for. We try to help piece together this timeline best as possible for the patient. Where we come into play is getting that pre-amputation consultation or a consult immediately after surgery, post-amputation, so that we can get in and provide education and start putting these pieces of the puzzle together. And that may involve fitting somebody with a light compression sock, depending on the physician and what their standards are for care. And then as soon as possible, we're doing that evaluation for the prosthesis so that we can start working with the physician and educating them if needed on what paperwork is required and starting that process of getting that insurance authorization. So that in itself nowadays can be pretty timely. So the sooner we can start that, the better. In most cases, that limb needs to be, if not fully healed, they need to be cleared by the physician for weight bearing and being ready to be fit with the prosthesis. But we acknowledge that because we're waiting for those benchmarks to be in place, in order to prevent the delay in their care of them receiving the prosthesis and walking out of the office with it, and attending therapy, which you see on the slide as a timeline. Within this process, we're trying to get that process started as early as possible. So we really are going to dive into the clinical aspect and the fittings and getting them to that delivery and the follow-up care system a lot sooner by starting that treatment plan as early as possible. So really our team works with individuals like Dr. Hoffman, which we'll dive into these details a lot more throughout the presentation, talking about that face-to-face, what that standard written order looks like, and most importantly, what does Dr. Hoffman provide from a physician standpoint from her notes and documentation and what those standards are from Medicare, and how we work together sometimes within those clinics to make sure that we have all the pieces kind of together and it makes sense for the patient and gives the insurance what they're looking for.
Perfect. All right, Dr. Hoffman, from your perspective, when you look at this timeline, where is it? Is it a fair timeline? And then is there a section in there that the hurdles tend to come up the most in your world, or what's your perspective on this timeline?
Oh gosh, so many hurdles in healthcare today, but I'd say probably one of the first hurdles is just having other providers realize that physiatry exists and how we can be helpful to this patient population and what we do for them. So having orthopedic and vascular surgeons who are performing the amputations connect a patient with us early in the process can be so helpful. And even as Mike hinted at, sometimes that pre-amputation assessment can be so key to giving the patient the right mindset and being successful after the surgery. So getting them connected to the right people in a timely manner can sometimes be a barrier. Getting them the appropriate post-surgical rehab, significant challenge right now, and the insurance companies are just throwing up barriers and creating new rules all the time. So it used to be very well accepted that post-amputation people would be going to acute rehab and getting high quality physiatrist-led rehab where we're focusing on shaping the limb and managing the residual limb pain and the phantom limb pain and doing, pre-prosthetic strengthening and training. And a lot of our patients are missing out on that now. So some of those inpatient barriers that we see, but then also making sure that once they do leave the acute care setting, that they have been established with a prosthetist and a provider who can help them navigate this ambulatory world where they have to get certain types of documentation in place to successfully get the prosthetic that they need once they are healed from the surgeon's standpoint and approved to either start shaping the limb the way Mike had mentioned and or bearing weight on the limb and being able to get into the prosthesis to start learning how to use it and how to start mobilizing again. So I know a lot of times we'll probably default to just vernacular that relates to the lower limb amputation because that is the vast majority, I think, of what we see. But there are so many upper limb amputations that need us as well. So in the ambulatory setting, it's a lot of, I think, coordination that is so helpful to get arranged for them inpatient so that they don't fall through the cracks when they leave the hospital.
So kind of speaking on not falling through the cracks, that's where having that prescription order from the surgeon or PM&R as early as possible to allow us to get in and see that patient, starting that light compression. Once they've kind of reached, us essentially, and we've seen the patient, we have a very routine follow-up process throughout the process to make sure that we're helping connect the dots and making sure that we're asking questions. Are you scheduled for follow-up with your doctors? What does wound care look like for you? When are they changing bandages? And really just kind of helping track not only the healing process and getting them started as early as possible, but making sure that they're taking the appropriate steps and they're educated on those steps to take with their physicians.
So that's fair to say. When you guys look at this timeline with the delivery and follow-ups, that's not just in our world. Right, Dr. Hoffman, in your world, after they receive that prosthesis, it's not like you've reached the finish line and you're done. Mm-hmm. Can you talk a little bit about your follow-up protocol too?
Yes, absolutely. And this is where I think PM&R physicians can be so helpful to a limb loss patient, the surgeons typically, once the incision has healed and the surgery is done, there's not really much involvement with the patient. There are some exceptions here and there, but typically once the patient is healed, the surgeon is out of the picture. And so physical medicine and rehabilitation physicians, we have so many patients that we follow for life. So we want to make sure everything that we do is about keeping someone functional for as long as they can be. And so everything that we do is about making sure that when those components of the prosthetic wear out, or they need new liners or new sock supplies, or they're having a flare up of phantom limb pain, or maybe they develop a neuroma. There are so many issues that can develop for patients after an amputation. Physiatry is really the specialty that will follow them for life as long as they need anything.
Yeah, the number of patients that I can think of that we've sent back to the physicians and scheduled them for PM&R for not only those things, but continued therapy. One thing that can be missed a lot of times is somebody gets a new device, and let's say they've been an amputee for 10 years already, and maybe they've gotten weaker, they've aged. There's other health factors that are playing a role and that they're starting to experience. We acknowledge that with this new prosthesis, it may make sense, or component, maybe even a new foot, new knee. Would it benefit to get you in touch with PM&R or your physicians to get a script for therapy so that you can continue to get the most out of your prosthesis and continue to reach those goals in life?
Absolutely. And I think there are probably a lot of providers out there that are not aware that Medicare does allow for maintenance therapy. So if something has happened where they've maybe lost some function and they need to get back to their prior level of function in the outpatient setting, Medicare typically allows for a certain amount of maintenance therapy.
Perfect. All right. Anything else on the timeline?
I don't think so. We're going to go into a lot more detail on all these things yet, so I'm always afraid to talk too much on this slide. Otherwise,
No, there's plenty of slides. Don't you guys worry. No,
every one of these boxes can be talked about for hours.
no one came to a paperwork presentation thinking there were 4 slides. All right, Michael, talk to us about what needs to be in that prescription.
So a lot of times this will show up early on as a, just a standard consult for the prosthesis, evaluate and treat for the prosthesis or device, as long as that individual has an NPI number, MD, DPMs, PAs, DOs, NPs. They're the ones that we're looking at this prescription coming from. But really, in the beginning, it's pretty vague. And it's not until they've been through that healing process that we're looking at determining the details about the prosthesis and what is then going to generate the SWO, which is what we're about to get to. So they're pretty vague, but again, the sooner that we get a script to not only consult that patient, evaluate them for prosthetic care, provide education, provide that early light compression, fitting a shrinker sock. Those are what those prescriptions typically look like.
Anything from your perspective on writing the prescription for those who are attending here who might be fulfilling those prescriptions?
Not necessarily. I know, especially if these orders or prescriptions are being created in the inpatient setting, so many providers across the country are using Epic, and it's a pretty standard order that it might just be a consult placed to the prosthetist / orthotist to come evaluate the patient. And I, in my practice especially, have noticed that, therapy has advanced so much and the prosthetic world has advanced so much, even though technically from a physician standpoint, I'm supposed to be the expert in this field. You guys know more about so much of this than I do, that an eval and treat order is typically all you need to get the process started.
Okay, beautiful. All right, so then we move on to that face-to-face physician's appointment.
So this is something that can be something that's described as a hurdle that most patients don't fully understand yet. That's kind of been my experience. Anything that's going to require a prior authorization, which is a lot in the prosthetic world nowadays, is going to require that face-to-face appointment with that physician, and it has to be within that 6-month time frame. But it's something that is a very necessary step in the process, and I'll kind of defer to Dr. Hoffman as to why this is so important.
Yeah, I think So are we already talking about like the ambulatory outpatient face-to-face? We're looking at getting the prosthetic order. This
Right,
is
yep.
the level that we're at right now. Okay. So I had, as we were talking about Epic, that those kinds of electronic medical records can be so powerful and useful that it helps us ensure that we are crossing all the T's and dotting all the I's that are needed in this kind of evaluation. So in our practice, we have actually set up a specific smart phrase, which is, within Epic itself, that covers the necessary components as far as the history of the patient's, illness, injury that led to the amputation, the current symptoms and challenges that they may be having, and then a physical exam that details what the limb looks like, what their range of motion and strength and incision look like, so that we're crossing all of those T's and dotting all of those I's. Are there particular areas of weakness or pain that we need to be addressing, whether it's an initial or a replacement prosthetic? And then the key components in our documentation, I think, as a provider, are explaining what the patient's functional level was prior to the amputation, and then what their goals are post-amputation. And that is going to vary widely depending on the person. And then describing what components of the prosthetic they will need to accomplish those goals. And then we've taken it maybe one step further, because Medicare is so specific about their requirements and so many other insurers follow them, that there is what's called a local coverage determination published by Medicare, by CMS, that details the components of a prosthetic that will be approved based on a person's certain functional level. And so we will absolutely just document that in our note and describe how the patient would qualify for those specific components of the prosthetic, and just put it out there before the insurance company gets a chance to try to say no, and then delay the process.
Gotcha. Okay.
Awesome.
Anything else on the face-to-face?
I don't think so. I like how you commented on the local coverage determination, because I think that's where across the board, from my experience in auditing and looking at the different documentation records that we receive, that is an area that I've seen PM&R kind of separate themselves from the things that they include. And across the board, if everybody can be educated about that and realize that that's out there, I think that's going to go a long ways in hoping that we can get that out in front of us and documented before the insurance has that reason to deny it, or make it any more challenging to get them the technology and the prosthesis that they deserve to meet their goals and their functional level. So that was a good point.
Perfect. And then I've noticed we got an uptick in friends who have joined us a little bit later, which is perfectly fine. If you notice your camera and your microphone is default to off, if you have questions, you have the chat option. You can type in a question and we can answer it live, or we can hold it off to the end. Just want to make sure everybody knew that. So, all right. So, what is an SWO?
So a lot of people may refer to this or recognize it as a DWO. It's been since changed to an SWO, standard written order. And this is really going to be, look like it's got a lot of foreign language on it to most, but it really is going to be a pretty detailed list of everything that's involved in the prosthesis that we've determined to be appropriate for that patient. So it's going to talk about the prosthesis in general in terms of materials being utilized, the socket design, the knee will be described on there if appropriate, and they're an above knee amputee, or whatever prosthetic components that they're going to be receiving is going to be on that list of L codes. That's the way that all of these are looked at and described and billed through the insurance. Prosthetic socks and all their consumables and things like that are going to be on this SWO. So again, it's kind of what is generated from our evaluation and us formalizing the treatment plan and as a team deciding what is best for this patient. So this is something that is always being sent to the physician to be signed.
So, Dr. Hoffman, you get to speak on behalf of all the physicians out there who receive these via fax and look at this itemized what looks like my bill from AT&T. This is everything that you got, and
Yeah.
it's overwhelming, right? Especially for a physician who has no idea what these L codes represent, right?
Yes, absolutely. And so much of it, as Mike indicated, is so patient specific because each socket may have to be different. Each pylon, foot, ankle, knee has to be different depending on what the patient's situation is. And so that's where the L codes come into play. And the L codes are the items that are described in that local coverage determination. And that's what helps us pinpoint this SWO. I have in front of me when I'm doing my note from my face-to-face, and I will pull out the specific codes that I know are challenging to get approved, especially if it's a microprocessor knee or what have you. And I will identify those in my documentation as a product that the patient needs and why, and what the local coverage determination indicates is approved for a patient based on their functional level. So I will just spell all of that out. And these have been very helpful for me in getting, I think, some documentation in place that gets us ahead of the game.
Perfect. Anything else on that guy?
I don't think so.
Okay.
That one's, to me, pretty straightforward, but yeah, it can look pretty foreign at times to most.
And it's important to know anybody who receives paperwork from us that looks like this, and if you have questions, call. If we have physicians or MAs on this presentation today, call and ask. We're more than happy to explain what is very overwhelming, especially to those who don't deal with it day to day. So never hesitate to pick up the phone.
And on that point there, and we'll be going into this later in the presentation as well, but there's going to be some information that we share and that we regularly send to the physicians to try to help connect the dots and to make what they're looking at a little bit more understandable or look at a little bit more clearly.
Perfect. So a fun story, I started in the prosthetic world in 2010, and one of the very first initial eval notes that I read from a prosthetist for a patient getting a brand new prosthesis read as follows. Mr. Jones was evaluated for a below-the-knee prosthesis. He is hoping to be walking by Thanksgiving. Period. That was the note in 2010. That was approved, by the way. Things have changed.
Oh my goodness.
Things have changed.
She was waiting for more to be added.
I know, you're waiting for more. She's like, oh my gosh, how much is he going to talk? No, that's it. 2 sentences.
I'm so jealous.
Yeah.
So things have changed significantly. So talk us through the documentation side of things. What do we need and who do we need it from?
So it needs to be very thorough, not only on the side from the physician, but from our evaluation as well. So our evaluation notes and documentation that we include covers a lot of information, really kind of diving into comorbidities, date of amputation, the status of that limb, what their previous activities look like, what their goals were, kind of looking further into those details on those activities. From there, what do we feel is going to be the most appropriate technology to put underneath them in terms of the prosthesis? We'll talk about the details of the socket itself and the design of the prosthesis, the suspension for the prosthesis, and really trying to paint this thorough picture of what is it that we're looking at achieving and why, and really trying to tie in this is the patient in front of us. This is what they present as. These are their goals. These are the things that are going to help them get back into life and achieve those goals and to be safe doing that. There's a lot of technology today in these different prosthetic components that make them that much safer. And it's getting the insurance to understand this is why we chose this versus that to get them back into everyday life and to do so safely. And then to take it a step further, to have them understand that there's going to be steps within this prosthesis based on what their limb presents as and the changes that they're going to experience to determine when is it appropriate to change those things in the future. I think to upper extremity when I say that because there's something in our evaluation documentation that we provide that explains this to be a tool for them. And there's not one tool out there that does everything. I think of a terminal device or a hand on a prosthesis, whether that's body powered or myoelectric, and how often that could be changed for different tasks that individual is doing throughout the day. So to get the insurance to understand that so that they'll approve not only that device, but potentially others in the future is pretty important. make sure that they realize that this isn't something that's going to be a one-time, one size fits all. It's a custom-made device specifically for the patient. And like everything, they change, their presentation changes, so we have to adjust with them. One thing that we also like to look at for getting this justified and to help provide that activity level, or what their functional level may be, and kind of what the patient's goals are, and why they're realistic, is current PT and OT notes as well. So we find that to be helpful. Again, kind of thinking of upper extremity and how often we refer to the OT notes to show what they're currently working on, showing that they have good EMG signals. All those things are things that kind of help tie this together to make it something that the insurance can look at and understand what we're doing and why.
Yep. So, Dr. Hoffman, for a short window in my career, I helped collect SWOs and notes from physicians. And what would always happen is the doc would get really used to those SWOs because it's a signature and a date.
We do love those.
They love those, right? And then it's like, hey, but we also need documentation and notes behind it.
Yes.
So again, and you get to speak on behalf of all the physicians out there. How important is this topic? And then what insights can you provide?
So here's probably the overriding insight that I can provide is that logic is not happening in healthcare in America right now. So things that we think make a lot of sense, like, oh, a person wants to be able to stand in a shower, and this is why they need this particular device in order to do that. We have to spell out in great detail why that would be important and more safe or needed for a patient. So that's probably the overriding thing, is I would say, as physicians, we get so accustomed to thinking, well, of course, because of this, but we have to spell it out in every note, and explain the thought process of why a person might need both a hook and a hand to accomplish activities of daily living and maybe hold a job and work like a person would want to. So it seems sometimes elementary or exceedingly annoying, but whatever detail you can put in as far as what the patient needs and why they would need this technology or device to accomplish it from the get-go, I think helps the process be a little smoother and leave less wiggle room for the insurance to deny.
Yep. I think that's a great point. That makes me think of how I start most of my evaluations with patients, even it's we're going to go through all this information today, and I'm going to be looking at gathering all these details. Because to you and I, it's pretty straightforward. We need a prosthesis so that we can get back into life. But it's really my job and the physician's job to then document and to show, again, this is what we're doing and why, in a very clear, vivid way that's going to not only be understandable to us, but the insurance, so that we can make sure that while we recognize you need, a certain foot or a knee or this type of prosthesis or this type of suspension, it's our job to make sure that they understand, the details behind that.
And we can't assume that the people that are in charge of approving have any expertise in this area, or sometimes even expertise in healthcare, period. So it just has to be as clear and understandable to anyone as possible.
Yep. And over time, as we've kind of created this PM&R clinic and relationship, there's keywords and phrases and verbiage that can be used that we will, work and do our best to share with physicians, that we've learned the insurances seem to understand and kind of focus in on, that has been successful in describing something or including in documentation as well. So, I think, again, kind of creating this team approach is really going to be beneficial to prevent a repeatable mistake or a reason for a denial just because he said something the wrong way.
Mm-hmm. Or didn't say it at all.
Correct. Yep.
There you go. Now, this slide is important because peek behind the curtain. Michael has a lot of notes on the written in the ledgers of his handout. So I want to make sure we didn't miss any of your points here.
I think we've touched on most of them.
Okay.
You kind of touched on this in a way. Is there anything specific that you think physicians should keep on top of their mind when they're getting into the process of writing a note to support prosthetic care?
I think probably in addition to describing the need for the technology, I think being very patient specific about their function, their goals, and anything that might be limiting them from achieving those goals that you know or think that the device is going to help them accomplish, and just spelling it out very clearly, I think is probably the key insight.
Cool. Thanks.
Because we live, I mean, not to speak out of turn, but in our world, patient motivation is something that's looked at first and foremost. That has to be documented.
Yeah.
So,
cognitive ability, compliance, all those things, motivation. Those are some things that are looked at because some of this technology nowadays, they have lights, they beep, they make noises, they have to be charged. There's things in your documentation that needs to show the insurance this individual has the ability to operate this, understand notifications that could be warnings or error messages, essentially a notification. We live in a world with smartphones and all this technology, so most individuals are using these devices on a daily basis that help show and prove that they have the abilities to not only operate their smartphone or their device, but how that translate into prosthetic care. And most people are charging a cell phone every night, so they have the ability to charge a knee or a hand or anything that's externally powered in that prosthesis. So there's things that we include in our documentation when we're looking at that level of technology.
But I mean, it can be so different, if you've got the 70-year-old farmer that is wearing it out in the fields versus the 14-year-old that's trying to run track. There's so many things that that you just need to cover and spell out that's so unique and specific to the patient that I think is most helpful.
perfect. All right, let's talk about K-level.
So
how do we get there?
We've talked a lot about functional level throughout this presentation. K-level is kind of the terminology again, the word terminology and the language of the insurance being something that we've touched on as well. K-level is how the insurance will identify that individual's functional level or abilities. And a lot of these K-levels are tied specifically to different categories or styles of prosthetic feet and prosthetic knees. Those are the main two components out there that are tied specifically to this patient's abilities because the technology behind them has to make sense for what their abilities are and what their goals are moving forward. So I always use this ridiculous example of you're not going to provide this big blade running foot to the 80-year-old lady in a nursing facility because that's not the appropriate technology or prosthetic componentry to utilize given her activity level and those goals. And by justifying what their K level is, kind of helps categorize and push a prosthetist into utilizing the right technology. So that's kind of the thought process behind these K levels and how they're used. K0 is going to be that individual who's not a candidate for a prosthesis or prosthetic rehabilitation at the time. They need to have external rehabilitation to make sure that they're rehabbing and getting to the point to where they're going to get the most out of this prosthesis, even if it's being able to put it on independently and transfer or get up out of that wheelchair and stand. There's a lot of low-level goals and functional abilities that somebody can have and still get the benefits from the prosthesis, but somebody who's considered a K0 essentially is not a candidate at that time. Where K1 is going to be that individual who's walking at that fixed cadence. That's the area that the insurance looks at pretty closely is their ability to ambulate at different speeds. What does it look like when they're up and moving? Are they using an assistive device? Are they able to go a certain distance? Are they able to achieve a certain walking speed? What does this mobility look like and how safe are they in doing so? So K1 is going to be that individual who's almost always, I picture somebody with a gait belt around them. The therapist is with them. They're able to walk, but it's going to be at a very slow, selected speed. And they're going to have some challenges and environmental barriers and doing things like stairs and ramps if they can do them at all. Where K2 is going to be that individual, while they're independent and they're up and moving in the community, they're still kind of going that select speed. They're not able to change their cadence. They're able to go up ramps and down stairs and walk in the grass, but they're going to do so very cautiously, and they almost still have that assist device in their hand. Whether it's a walker, a cane, crutches, you name it. Where K3 is going to be that individual where most of the time, if they're wearing maybe long pants and they're below the knee or a lower limb amputee, they could come walking down the hallway at you and you not recognize at first that they're an amputee. They get around that well. They can go fast, they can go slow. They're going to do just about anything they want to, maybe a little bit differently and with a little bit more caution, but you're not going to be able to recognize it as easily with the naked eye. Where then you go to the other end of the spectrum at a K4, who's going to be that younger population, running, jumping, high impact stuff, sports. And a lot of times when we get into that K4 category, we're providing kind of a recreational or sport or activity specific prosthesis and technology. It's not something that they're always going to be walking around with on a daily basis. So while there's struggles in getting something like that approved as well through the insurance and having to have a whole bunch more detailed documentation, that is an area that is being looked at currently, and they're trying to change the resources available in that K4 world.
I've always said I have K4 potential. So, Dr. Hoffman, how important is it for physicians to familiarize themselves with K levels?
Oh, I think that's vital. For anyone who is ordering a prosthetic, you have to know and understand the K levels, because if you don't, you're creating a delay for your patient and more paperwork for yourself. So if you can't, and this is a part of what our pre-populated note already has in place, it cues us to document the K level of the patient in the note. And then we also describe what that K level means in each note. And then that local coverage determination ties different technology and components to that specific K level. And then we spell that out specifically. So, Mike brought up the cadence, and that can be a key differentiator. Is this person able to walk on uneven terrain and change their speed or change their incline? And is there a component of the device that will help them achieve that goal? And so it's specifying things like that directly relates to the K level that can be so key in making this approval process smoother.
So when you look at that graph, and this Mike and I talked this morning that this would be a really good place to talk about skilled nursing home patients, because that K0, K1-ish, world is common for if we have therapists here coming from the skilled nursing facility. Are patients stuck at a K level forever, or can they improve? How does that work?
Absolutely. I mean, every patient changes as they progress, as they heal. If they're in a skilled nursing facility, why are they there? Did they have the amputation 10 years ago and then they were just recently hospitalized for a heart failure issue and now they're a little debilitated? So this snapshot at the moment, when maybe they need a replacement, is a different functional level than what they could be once they're finished with their rehabilitation in the skilled nursing facility. So K level, I think, absolutely varies depending on the person's current status. And then, even when it's an initial process, as they continue to heal, the challenge is really the vast majority of our patients that have amputation are vasculopaths. And so maybe they have challenges with healing, or maybe they have other cardiovascular issues that limit their activity and function. Maybe that's a long-term issue. Maybe it's a short-term issue. So understanding and being able to provide the patient with what they need at that time, but knowing that as or if their condition changes, their K level may very well change.
And then talking about the skilled level, can you talk about the difference between Med A and Med B?
Yep. So that is an area where the insurance is really looking at a time frame of that individual's stay. Are they considered, and that may vary whether it's a skilled nursing facility or an acute rehab setting, but that really limits us sometimes on what we can provide and when we can provide that level of care. And it kind of, looking at that timeline of when we have to receive all that documentation and kind of put the pieces of the puzzle together, it kind of really highlights the priority that we have to take in getting sometimes those things achieved so that we can provide care to them while they're either in Part A or Part B and they're looking at getting ready to be discharged. Do you have a lot of experience in Part A and Part B?
I mean, enough to be dangerous.
Yeah.
So I have in my life been the medical director in both the skilled nursing setting and the acute rehab setting. And so I do know with my medical director hat on that financially, sometimes it's challenging to order something like this, or sometimes even just an orthosis when they're in a Med A stay. And so sometimes that it's the financial picture that really guides what you order and when.
Mhm. Yep, absolutely. And sometimes it can dictate from a prosthetic standpoint or orthotic standpoint, you know, certain parts of that prosthesis are covered by the patient's insurance versus looking at generating a PO from the facility that they're at and getting something covered through that means, and having that conversation and making sure that there's things in place to make sure that we're not delaying the patient's care while they're going through this kind of rehabilitation journey and working on their way getting back home.
Perfect. For sake of time, I'm going to move us along. Just a quick note on that bottom left-hand corner, upper extremity prosthetics, there are no K levels for them, and then neither for bilateral lower extremity.
Correct.
Yep, got it. All right. How are K levels determined?
So we utilize essentially this application called ProApp, and within that we have a number of outcome measures, whether they're self-reported or they're functional outcome measures. One of those outcome measures that we do that are functionally driven is the AMP, stands for Amputee Mobility Predictor. It's the AMP Pro with their prosthesis and the AMP No Pro without their prosthesis. And it's essentially a series of tests that you're physically putting the patient through that test their sitting balance, their standing balance, their ability to ambulate. Are they able to walk fast, slow, stairs? So there's a lot of variables or things that are looked at within that test that help essentially provide a numerical value that generates a K level. So it's kind of the gold standard in the world of prosthetics of outcome measures, and something that's going to provide a K level to not only allow you to speak on what their goals are and their pre-amputation activities are, or what the activities currently look like in therapy, but a quick snapshot of this is what this patient looks like today at this evaluation. Therefore, it shows that they are this functional level, making this technology or this component appropriate for them for their current, you know, place in life as an amputee or in the rehabilitation journey. And to your point, you mentioned earlier, you know, can an individual change in K levels? These are things that are repeatedly done throughout the rehabilitation process and their care here at Perez Prosthetics to determine, are they advanced? Is there something out there that would be better for them with where they're currently at and what their goals are, not only currently, but moving forward as well. So, you know, it's a good way, these outcome measures that we're taking is a good way to help motivate and to show the patient that they're sometimes, you know, maybe struggling through this rehabilitation journey because they always have in mind that they want to be here, right? This much further than where they pictured themselves currently. It's a good way to be able to look back and show the progress that they're making and how beneficial therapy is being, and the milestones that they're reaching. Even though they're small steps, they're still moving in the right direction. So that's why we do a number of those outcome measures, not just the AMP, but that one being one of the key factors in providing justification and showing their current functional level to make sure that the prosthesis that we're providing is appropriate for them.
Anything else from your perspective?
No, I think you guys do just a lovely job of assessing, I think, the whole picture of the patient's health status. But from a provider standpoint, that is something that we have to bear in mind. The other medical comorbidities that could be contributing to the K level, in addition to the amputation, and then the cognitive level is not something you can overlook. Can they don and doff the prosthetic? Can they manage a microprocessor knee? There are lots of factors that we have to look at.
Wonderful. Right. In our last 10 minutes, we're going to call this Death by PowerPoint, where we're going to read every single bullet point to you on every single slide. I'm kidding. No.
How dare you?
So basically, as you have your handout, and you will receive one if you didn't get one from me Tuesday, you can kind of take a look at these last slides. This is really in the physician's world. You're going to see, here's lower extremity and the initial, like basically their first prosthesis, and here's a replacement, and here's upper extremity, and here are replacement sockets, and here's orthotics. So we'll kind of just encapsulate this one section at a time. In your world, Dr. Hoffman, what's needed for that initial first prosthesis in terms of notes?
So it's a lot of the things that we have discussed. It is their current medical status. It is their medical comorbidities. It is the condition of the limb. It is their range of motion and strength. It is a gait analysis. We do a gait analysis in the clinic when we're seeing a person. And then we're also checking pain and limitations and how they're moving with the device and whether they have the devices that they need to be successful. And then documenting based on what we have seen and what we know about that patient, and then the assessment that the prosthetist has done and shared with us with the functional level and the patient's goals, what's the appropriate device for the patient.
So you'll see these next few slides have a lot of bullet points, and like Theron said, it's kind of a lot of information there to digest. We're not going to read through every one line by line, but a lot of them are pretty comparable to one another. So we actually will do our evaluation, and we can either provide a full written evaluation to the physician at their request, if it's something that would help them put together their documentation, after that they've had that face-to-face and that they're looking at doing their documentation and making sure that their evaluation kind of speaks in, parallel to ours. But we've recognized and identified these specific Medicare standards again and what is required by the insurance. And we'll essentially put together a letter that's got the bullet points from our evaluation that said, hey, these are the things that we know the insurance is going to be looking for. This is what our evaluation found. After you do your evaluation, if you agree with these things and our findings are the same, and if you don't have any questions, please include this in your note, in your documentation as well, because this is essentially what is needed to help make sure that this is approved. And then, taking it a step further with the things that we've discussed today, tying in the LCD and all the details and specifics is going to just make that note that much stronger to make sure that we avoid the risk of that denial being something that we face that's not only going to potentially delay that patient's care, but again, just be that frustration in front of all of us because we may be at that point where that patient's ready for that prosthesis, and we're kind of fighting that background battle of getting documentation and the insurance to give us the thumbs up to make sure that this patient can walk out of our office as soon as possible with this device. So, again, just one of those things that we do in addition to fielding calls and answering questions and whatever that needs to look like to make sure we're on the same page. Providing our documentation with that SWO, such as the bullet point letter, is something that we've learned is helpful and we're happy to do as well. So that even if you're listening to this presentation today, you don't have to memorize all the specific details about what we've covered today. We kind of try to help take it in a snapshot and send it right to them.
I don't want to just skip ahead to upper. Is there anything else on the lower extremity side? Okay.
I think so.
All right. So we'll go to myoelectric, if that's okay with you.
Yeah, that works.
So let's talk about myoelectric in the myoelectric world.
So I kind of touched on this a little bit earlier in terms of some of the things that need to be proven or shown. Cognitive ability is a big one for myoelectric. Overall, their ability to achieve EMG signals, which is how they're going to power this device or control this device, essentially. Sometimes that involves, again, the team and getting them involved in OT and that being in the OT notes as well as ours. But really speaking to the limitations of this device, how it's going to serve a specific purpose and what those purposes are. Typically fine motor skills and things that aren't heavy duty use, don't involve being in around an environment that's really wet. So really kind of, again, painting that picture for them and making sure that they understand what is the goals with this prosthesis and the benefits behind it. Because as much as none of us like to look at the cost of a device, we know the insurance does. And myoelectric's definitely up there in terms of cost and what we're requesting that insurance to pay us. So or we're not requesting, but that's all dictated by the insurance and the L codes that were provided. So we don't set the costs.
Right.
But essentially it's something that I think creates a lot more red flags along the way of an insurance. And I've seen items that have a little bit more technology involved draw those red flags and then be a little bit more specific about what's included and run into denials. But again, with kind of this team approach, I think if we all have kind of the same verbiage and kind of the same outlook as to what this documentation looks like, I think it decreases the risk of running into those denials.
And from your perspective in the upper extremity world.
Yeah, absolutely. Is it the right device for the right patient? Myoelectric is heavier. Can they handle a heavier device like this? It's more complex to manage and take care of. And are they, working in a battery factory with dust particles and they can't wear it at work? So lots of factors that have to be very patient specific and documented well to make sure that you're getting the right product for the right patient.
Perfect. Just for sake of time, because I do want to let everybody out right at 1 o'clock, this is your chance. Throw some questions into the chat if you have any before we wrap up. I am going to skip just real quick to orthotics, just to say we did it, just to say we talked about it. What's the big takeaways for the orthotic world?
So orthotics, I'd say one of the key takeaways would be kind of the patient's limitations, that tie to their diagnosis. What are they lacking in strength or range of motion? What is the existing deformity or weakness? What does that look like? How is this brace or orthosis going to help with making them safer, providing stability around whatever joint we're crossing, to make sure that we're essentially regaining not only some independence sometimes in those next level of activities, but really providing safety, and how this kind of ties into the rehabilitation goals that are currently in place and they're already working on. Not uncommon that a lot of times physical therapists may identify the need for these in therapy, and that's where we can then get involved. And sometimes, the request for us to come do an evaluation or a consult with the patient comes from is the therapist that's seeing them pretty consistently and frequently and seeing their limitations that they have without an orthosis and how it's going to benefit them. So again, it's just kind of explaining how is this going to best help the patient and making them safer, preventing further deformity, and kind of get them going on the right path.
Dr. Hoffman, we'll let this kind of be our wrap up. You can chime in on the orthotic world or anything that we missed or anything that you really want to make sure that our audience has a takeaway today.
I would say from the orthotic world, the documentation burden for the providers is much lower. And then, we're, I think, evaluating what's the appropriate orthotic. Can we accomplish it with an ankle foot orthosis, or do we need a knee ankle foot orthosis? Does it have to be custom, or can it be off the shelf? So less burden, but still some items that we need to document and tying it to the appropriate diagnosis. I can't assume that because a patient has hemiplegia from a stroke, that's going to qualify them for the AFO. Maybe I need to document that there is foot drop. So, just saying those magic words in the appropriate way. And I think as a general wrap up, I would say, and if you have a patient that has an amputation that is having challenges and is not established with a PM&R physician, please ask them to find one, because this is what we do. This is where we can be helpful in not just making sure that they have what they need from a prosthetic standpoint, but making sure that they have everything else that they need to be functional and successful after limb loss.
Absolutely. And you guys noticed, I put pictures of our patients and our success stories, will be linked in your email because with their certificates, because this is what it's about. These are the people behind all of this paperwork, right? We take it very seriously when we say they're not just numbers. They're not just patient ID chart numbers. It's Mr. Jones who just wants to walk the mall. Okay, and I want to have one quick Q&A real quick. Thank you so much. I almost missed it. Is there any time limitation when it comes to getting a new prosthetic for insurance to cover, for example, 5 years like DMEs, or is it all just based off of the patient needs?
I think it's a combination of both. So when it comes to replacing components, and Mike could speak better to this than I can, there are certain timeframes for warranties or coverage to replace components that have worn out. But when it comes to a change of limb or a change in medical condition that merits a new component to the prosthetic, then that can be just more patient specific. And it's not as strict as, say, the Medicare rule that they can only get a new wheelchair or mobility device every 5 years. There is, I think, more wiggle room here than there is for DME.
Nailed it. Yep. So pretty much physiological change is what we're looking for in terms of a replacement socket, prosthesis, change in functional level. But as Dr. Hoffman hinted at or talked about, the timeframes may be a little bit more specific to components given the condition of them, if they are still under warranty, if they can be replaced or repaired. Those are things that we document as well if they're looking at replacing something, even if it's outside of the warranty period.
All right. We are at 1 o'clock. We really appreciate everybody joining us today. You can log off. You are good to go. Dr. Hoffman, thank you so much.
Thank you.
Wonderful insight. This is going to be recorded and put on YouTube, and it will be out there for forever. So, but we're going to let everybody take off for the day. Thank you again so much, and everyone have a great weekend.
Thanks,
Thank you.
everyone.
Bye, guys.
Bye.